Okay, so we're talking about erosions in rheumatoid arthritis. And remember, we talked about kind of three stages: the acute stage, which is dominated by osteitis; a subacute stage, where you start having a hole in the bone with some containment of the inflammatory response; and then chronic phase is when you start getting scarring and healing in of the lesion. And this just shows 1.5T images of a patient with rheumatoid arthritis. Here's what an acute erosion looks like with indistinct margins and a lot of surrounding osteitis. A kind of a subacute erosion where you can see sharp margins, but it's very bright with a lot of edema in the inflammatory tissue. And then the chronic erosions where you start getting in the fibrous tissue, filling in the lesions without a lot of bright signal intensity within the bones. So those are kind of the progressive stages of erosions in rheumatoid arthritis. John, were you going to say something?
I did. I mentioned that looks like a cystic lesion.
Yeah, but it's this is actually filled with inflammatory tissue.
There's quite a bit of fluid in joints, rheumatoid joints.
Yeah. Okay. Now, looking at these, this is obviously low field scanners, but stage 1, you get osteitis. What it's typically seen with MR is low signal intensity on T1 weighted images because of the edema and or replacement of the fat by inflammatory cells with indistinct margins. And this is this is a gradient echo T1, and this is a stir sequence showing kind of indistinct margins of this area. These are generally not visualized by X-ray techniques, including CT, when it's just the early osteitis stage. Here again, we can see also gradient echo T1 here to the left, erosion, but we can see this is mostly osteitis with indistinct margins. Again, it's at the insertion site of the capsule, which is the typical location where these start. So that's osteitis, and it's pretty specific for inflammatory disease. And here, this is stir sequences, no osteitis, and here's the same patient at a later stage showing the osteitis within the capitate. Okay, Elior, what do you think of this case?
Right, so looking at the third MCP joint, I see a lot of subchondral sclerosis. I see erosions of the bone where that capsule inserts. Yeah.
And this is what it looked like on a low-field MR examination. So here you can see where that erosion was, but you can see the erosion can often be much larger on MR than what you can see with X-ray based techniques.
Mm-hmm.
Okay, and then here's more end-stage rheumatoid arthritis here with a typical pencil and cup deformity that we were talking about last time, where you have a synovial thickening and inflammatory disease, which erodes the subchondral bone on either side, leaving a little space here where the bone is not yet eroded away. This is the pencil, and here's the cup, which is the phalangeal base. And this is less extensive, but again, another pencil and cup deformity of rheumatoid arthritis. And here's a sagittal image right through the bone right here, showing that these erosions start on either side and erode inward, and anterior posteriorly we don't see the erosions at this stage. There are other low-field scanners, gradient echo T1, stir sequence. In here we can see extensive osteitis, destruction of the articular surfaces here within the wrist, both the radial carpal as well as the intercarpal and carpal metacarpal joints. It's very typical of rheumatoid arthritis. Here's a more chronic stage of rheumatoid arthritis. You can see innumerable erosions, marked synovial thickening. We see here an extensive destruction of the articular surface, large subchondral erosions involving the distal radius. So this is something we really hope not to see now that there is a good treatment to stop this disease much earlier along in the course. So this is chronic, long-standing, destructive rheumatoid arthritis. And this is just some data that we published back in 2006. We looked at 156 patients, comparing 246 different MR scans. The average interval between the MR scans was 8 months, varied between 1 and 19 months. And we found about 50% of the time these patients at this particular time on different treatments showed no progression. We saw progression of about 30%, regression in about 15%. We could see some patients that had both progression and regression. And then there was a few cases where the motion artifacts was such that we couldn't really see the study. So MR scan can be useful to follow these patients. This was a time when TNF-alpha inhibitors were not used as aggressively as they are now. I would suspect that progression would be much lower today with the use of much more effective medications than in the early 2000s. That was when they were first coming out. Okay, Tayson, what do you think of this case?
It looks like we have a lot of synovial thickening of the wrist joint, and then like osteitis at that proximal scaphoid.
Right.
Some erosive changes
Right.
within the triquetrum.
So that's 9208, and that's, as you said, proximal scaphoid osteitis, a lot of erosive. So this is 9208, and the patient came back on 8/2/2010. What do you see here?
Okay, so this has become, progressed from an osteitis to more of an erosive look to it.
So this was a patient who was placed on methotrexate, I believe, and it helped control the inflammatory stage, but then we could see well-developed erosion at this particular time, right there. So you'd like to pick up the osteitis as early as possible and treat it effectively. And generally, it's pretty widely recognized now that the TNF-alpha inhibitors are more successful at treating the osteitis than methotrexate alone. Okay, Tayson.
All right. Looks like a gradient echo.
Right.
It looks like there's maybe some osteitis of that scaphoid, maybe an erosion at the base of the first metacarpal.
Okay. So this is on 3/11/09. This is on 10/4/2011. I believe, if I remember, this patient was put on methotrexate, not TNF-alpha inhibitors. What do you think's happened in between?
So that region of osteitis or erosion in the scaphoid looks like it's larger.
Maybe a little bit larger here. What about in the trapezium?
Oh, yeah.
And what about in the first metacarpal?
Yeah, it was so dark that I thought it was a different sequence for a second. So it looks like a lot more involvement of that trapezium and
So this is progressive erosive disease. And so at this particular time, I really thought that MR might be helpful in following these patients. so that you would, if you see progression of the erosions, you could then jump to more aggressive treatment and keep these extensive destructive changes from happening. And there were some studies a few years ago to try to use MR that way, but they were kind of inconclusive in showing MR being effective at doing that. But MR typically is used more aggressively in Europe than in the United States for a number of reasons that I don't want to go into right now. But MR is the technique of choice really to follow erosive changes, and these changes can become pretty massive if they're not carefully followed. Generally, once you go to a TNF-alpha inhibitor, the erosive changes will stop and regress, though occasionally they can even continue to progress on some of the TNF-alpha inhibitors, and occasionally you have to change the one to find one that's effective in a given patient. Okay, Elior.
Right, so we see some erosive change in that distal ulna.
Okay, so here's an erosive change, a big erosion in the distal ulna. We can see there's a break in the cortex here, and then we can see this, what looks like a large erosion on the gradient echo and the stir sequence on this low field scanner. This is on 12/21/05. This patient was then placed on TNF-alpha inhibitors and methotrexate, and then followed over time. And then the patient came back in 2007, and this is what it looked like.
Yeah, that erosion's gotten much smaller.
Yeah, so these erosions can get smaller. Now, let me see if, no, okay. So what's happening here? How can these get smaller? Well, I believe what happens, these get smaller, is what we're seeing here is an area where you have dense inflammatory tissue around trabecular bone. And the center, you dissolve the most trabecular bone, and there's a point where once you dissolve the trabecular bone and there isn't any left, there's no longer a scaffold there to allow the bone to heal if you stop the inflammatory process. And therefore, when you stop it, you'll end up with a geode or a hole in the bone. In areas around the periphery where the trabecular bone is still intact, once you stop the inflammatory process, the osteoclasts come in to remodel the bone and can remodel the bone, and so it looks like the erosion has decreased in size. Whereas what's really happening is that you're stopping the inflammatory process and allowing the bone to heal where there is trabecular bone. In the center, where the trabecular bone has been destroyed, the body no longer can recreate the trabecular bone because it doesn't have a scaffold to work with, and you end up with a geode or a cyst within the bone. So this is an improvement on TNF-alpha inhibitor, and therefore it's important to detect these early on when you still have a lot of bone intact. John?
Of course, if you wish, you can graft these. I'm not talking about this lesion. I don't think I would graft it, but there are lesions that you can graft while they're healing. And even though they become permanent, you can graft them and make them look much better.
Thank you. Okay, Tayson?
All right, looks like we have erosion of that ulnar styloid and the lunated triquetrum. It's a lot of synovial thickening there.
Right. Okay.
And also in the state.
7/21/04. And then now you came back almost 3 years later, and this is what it looked like.
Well, there are definitely more mature erosions, but they were definitely smaller in area than the original.
Right. So this is basically, again, after putting on treatment, in this case with a TNF-alpha inhibitor, you can see that it's allowed healing. We've gotten rid of most of the inflammatory disease, and then it's healed as much as it can. But again, there are areas where you have irreversible damage that you're not going to get back with medication alone. Yeah. And here's 4/4/2006. And then here we can see after putting on treatment, the erosion is much smaller. The inflammatory disease is much smaller, and you're left with a much smaller erosion than you saw in the original study. Yeah, here's another example. Let's just look at this erosion. Again, these erosions tend to start on the margins. This is a subchondral erosion. This is most likely due to degenerative disease rather than rheumatoid arthritis. Rheumatoid, as we've told the pathologists tell us, typically start at the capsular insertion. And then in this case, this patient was put on methotrexate, and you can see the erosion increased in size over 3.5 years. And we can see here, it's not really undermining the articular cartilage. Here, the erosion has increased where it's undermined the articular cartilage, leading to degenerative disease where you no longer have the intact subchondral bone. The articular cartilage then is destroyed, and you start developing typical degenerative disease. And you can see how if this happens on both sides, you could end up with a pitfall and cup deformity that we were talking about before. Here's another example over here where you have these typical marginal erosions, the typical kind of erosion seen with rheumatoid arthritis. And this is 6/20/2006. Again, these low-field scans, we can see a lot of marginal erosive changes. And if you follow it over time, marked increase in the erosive changes. So again, MR is by far the best way to follow erosions. And now for clinical trials and looking at effective treatment for inflammatory disease, generally the FDA requires MR data in following those patients, even though MR is not used that much clinically in following individual patients. It's important data for clinical trials. Again, here we can see osteitis and the capitate on these low-field scans. And over time, this is 7/18/06. A little over a year later, we can see an increase in the inflammatory disease involving the capitate. So MR is really, and other erosions here. Okay. And a lot of people like doing CT for erosions, and that's fine for erosions, but the real pathology here is the inflammatory disease. So I really prefer MR because it's the inflammatory disease you treat rather than the erosions. And you want to try to pick that up before you have actually CT detectable erosive changes, which are irreversible. And then here's just an example of rheumatoid arthritis really going untreated over many years with really complete destruction of the carpal bones, the distal radius and ulna and proximal metacarpals. Again, typical marginal erosion seen in rheumatoid arthritis. In this particular case, they replaced these joints by prostheses, which we can see here. And John, you can tell us a little bit about the success for these joint replacements in rheumatoid disease.
These are silicone implants, which we used in the 70s. They worked about a year or so, and then they broke and produced particles that had to be removed.
Yeah.
But they did not work. Silicone does not do the job.
Yeah, and here's one in the base of the thumb. Okay. So let's talk a little bit about pitfalls and looking for erosive changes. One is nutrient foramina, can sometimes look like erosive changes. There's a typical irregularity at the base of the second metacarpal bone that can look like an erosion, but it's normal anatomy. And then there are grooves on the dorsal and volar aspect of the capitate that can look like erosive changes. So especially dorsally in the lunate, you'll often have the nutrient foramina where the vessels enter the lunate, and these can actually look like erosive changes, except they're in a atypical location for rheumatoid arthritis for early erosions. and typical locations for nutrient vessels, which are typically dorsally, whereas the rheumatoid erosions tend to, again, start where you have the capsular insertion, as we've been talking about. Also on the capitate, you can often get things both volar and dorsal, which are folds within the normal bone that can both have nutrient foramina and can look like erosive changes. So you have to be careful of these. These are actually the nutrient foramina going in. And on the sagittal images, you can see indentations both volarly and dorsally, which, when viewed in the coronal plane, can sometimes look like erosive changes. So you need to look at these in multiple planes. And then again with MR, if it's someone who's not on TNF-alpha inhibitors, you need to look for the inflammatory changes, which is something you can't see by CT.
Well, the proximal row is very much gone, isn't it, John?
Here? You mean on this one? Yeah.
Not on this one right here.
Yeah. Well, this is a cut in between the lunate and scaphoid, so we're in between the bones.
Like I said yesterday, we don't have prosthetics that work very well. They last for a while, but most of the time they wind up with a fusion of the wrist.
Okay, and then another thing that you can often see on the coronal plane are these kind of grooves, both volar and dorsally, involving the capitate, which are normal anatomy. And if you get kind of partial volume of these grooves can be a little bit irregular and can look like erosions. But so on the sagittal images, you can see that you can follow them and see that they're really normal anatomy and the underlying cortex is still intact. And then here's the typical little divot that you can see at the base of the second metacarpal bone, which is a normal anatomy of the second metacarpal bone. I've not seen this on the others, but it's very common on the second and is not an erosion. Okay, I don't know who's next. Elior, what do you think of this one?
71-year-old female with rheumatoid arthritis treated with methotrexate on the day of this MR. So yeah, we see a lot of erosions of that that proximal carpal row. We see proximal
a lot of edema, a lot of osteitis, right?
Yep.
Now, what I want you to look at is the capitate and the scaphoid here. Notice you can see the intact cortical margins on both sides here, but there's a lot of inflammatory. There's a lot of increased fluid, which is actually could be edema, but is generally replacement of the fat cells by inflammatory cells. So it's a true osteitis here within the capitate, and to a lesser extent within the scaphoid. So this is on 12/6/07. So extensive osteitis. And now the patient and this is on the axial images where we see that interface between the capitate and the scaphoid. And then now the patient came back after being started on methotrexate to decrease the inflammatory disease, came back a year and a half later, and this is what it looked like.
Right, there's improved, decreased osteitis in that capitate.
Okay.
Looks like bone fusion between the capitate and the scaphoid there.
And a fusion across the here. So now the osteitis is basically markedly decreased, maybe a little bit in the distal radius, but now we have bone fusion. And these fusions are very common with rheumatoid arthritis, and I think is what happens with these is if you get osteitis on two sides of a joint, that osteitis will affect the subchondral bone, and just like we saw in the metatarsophalangeal joints, will cause the articular cartilage to disintegrate, and then you'll have inflamed bone against inflamed bone. Then when you give methotrexate or some other disease that stops the inflammation, then the bone heals, and when you've got two raw surfaces next to each other, when they heal, they'll fuse together. I think that's what causes. We've seen a number of fusions develop following them with MR, and that seems to be the typical process which leads to fusions in rheumatoid arthritis. So
we used to fuse the bones surgically in many different combination of bones before the days of treatment.
Yeah.
The treatment was just temporary.
Good.
But methotrexate, that is one of the first drugs that was used for chemotherapy, and it was 100% curable of the choriocarcinoma of the endometrium. Just to give you a little history, that goes back to the 60s.
Yeah, I can remember when I was in medical school, it was kind of one of the drugs of last resort. So patients who had cancer who would put on high-dose methotrexate, it was kind of the marker of kind of the end coming. And so I was surprised in the 1990s when they started using methotrexate for rheumatoid arthritis, but they used it at much lower doses than for cancer. And it was actually really the first spectacularly successful drug for rheumatoid arthritis. Okay, and here's just another example of bones and rheumatoid arthritis, and they fused over time on therapy. And this another patient, typical kind of multiple bony fusions that you can get in long-standing rheumatoid arthritis. Again, hopefully you guys won't be seeing very much of this in practice because now these patients should be treated long before they get to a point where they're going to have bone fusions like this. But these are the typical kind of fusions that we used to see in rheumatoid arthritis. So let's go on and talk about soft tissue injuries in rheumatoid arthritis. We can talk about tendonitis, subluxations, and then some of the named deformities that we've already talked about. Tayson, are you next?
Yes.
Okay.
All right. 80-year-old female with outright inability to extend the fingers. It looks like the fourth and fifth extensor compartments are, the extensors look like they're absent.
Yeah, it looks like that's
There's one, and then there's some ulnar subluxation of that extensor carpioulnaris as well.
Yeah. Yeah, so here what these are, and here we can see these are tears. I think I might have showed this during the tendon section as well, but these are tears that you can get rheumatoid arthritis, probably due to the chronic inflammation, weakens the tendon. It makes it much more susceptible to tears, and that's why they couldn't extend the fingers. Let me talk a little bit about ECU. In long-standing rheumatoid arthritis, virtually 100% of them will have subluxation of the ECU. And we did a little study looking at those. Basically, 100% of those patients will be asymptomatic in the area of the distal ulna, as opposed to young athletes that get traumatic displaced ECUs, where 100% of them will be highly symptomatic in that location. So instability of the ECU, really kind of destruction of the subsheath and even the overlying retinaculum can occur in rheumatoid arthritis, and it generally is not a source of significant patient symptoms. But I mention it anyway in the report. So these are extensor digitorum tendon tears from chronic inflammatory disease. Elior.
What we used to do, if one tore, we used to just connect it to the other tendons.
Yeah.
because they work together anyway.
Yeah.
They worked out pretty well.
Good.
Right, so here looking at the ECU, I see Martinez synovitis, some fraying of that tendon. Yes, some erosive change in that ECU groove.
Good. And then here are the coronal stir sequences where we're getting part of the first compartment here as well as the sixth compartment, and we see a lot of fluid in both of those compartments. And let's see, this is on 7/18/2018, and then the patient came back on 9/2/2009. What do you think about what's happened in the interval?
I don't see the ECU tendon.
Yeah.
I think it's torn.
And it's gone.
The first extensor compartment looks a little better.
Right. Yeah, so that was a complete rupture of the ECU that developed over time. And you can see at the beginning, it looks like it's pretty small. So it was well on its way to complete rupture back in 2008. So again, tendon ruptures in rheumatoid arthritis. Tayson.
All right. So it looks like we have a tear of that extensor tendon with laxity, a lot of remodeling of that distal radial ulnar joint.
Yeah, and then here we can see that it's torn and kind of retracted back on itself. So that's why they couldn't extend that fourth digit. Okay. And then we've talked about subluxations, and this is the typical volar proximal subluxation of the metacarpophalangeal joints that's pretty pathognomonic of rheumatoid arthritis. And here we can just see the more prominent volar subluxation and proximal retraction of the proximal phalanx, chronic dislocations. And then here we've talked about it, flexion proximally, extension distally, and separation between the flexor tendon and the bases, and that was a boutonniere type deformity. Here we have extension proximally and flexion distally, and displacement of the tendons, so they're not over the back of the bones anymore. So they're pulling along the sides in the wrong direction, which leads to this extension at the PIP, and this is what's called a swan neck deformity seen in rheumatoid arthritis. So the kind of deformity depends kind of on which of the supporting structures are torn due to the chronic inflammation. And then here's another example of the flexion proximally, extension distally, probably an A2 pulley tear, and boutonniere deformity in rheumatoid arthritis. And then here's what the thumb looks like. It's fixed in this position, so you have extension of the interphalangeal joint, flexion of the metacarpophalangeal joint of the thumb. This is what the left looks like, and here again, this is caused by tearing of the sagittal band, subluxation of the tendons, so they're pulling now from the wrong direction. And this is called hitchhiker's thumb. This is on the left, and this patient has the same thing on the right, with dislocation, in this case, of the interphalangeal joint. So a lot of weird problems with chronic rheumatoid arthritis if you can't control the inflammation, and it goes on to destroy the supporting soft tissue structures of the hand. Let's see. Tayson, what do you think of this case?
All right, so looks like the extensor tendons are all subluxed laterally. And yeah, there's a lot of synovial thickening within the flexor tendons.
Right. Yeah, so we don't really see the extensor tendons there very well. And we can see this destruction of the metacarpophalangeal joints, a lot of thickening posteriorly, and these are actually rheumatoid nodules. So that's what a rheumatoid nodule looks like on an MR examination.
Most rheumatoid has the tendons, extensor tendons go lateral.
Yeah. Okay, Elior.
Looking at the second digit, we see a lot of soft tissue thickening along that volar aspect. I don't see the tendon very well.
Okay.
Down the sagittal view, yeah, we see the tendon well there, but there's, this nodule in the soft tissues that could be a rheumatoid nodule. Yeah.
Okay. Tayson.
All right. There are some surgical changes here. Is this a plate and screw fixating the dorsal wrist?
Right. So what do you think this is?
Looks like ankylosis of that.
Yeah. So this is a surgical fusion. John was talking about these before.
That's a typical way that's done. You fuse the wrist, and then you also fuse the metacarpals.
Yeah.
Usually you take the middle finger and fuse that.
Yeah. So that's surgical. There are actually some surgical fusion, and actually there are actually some non-surgical fusions here as well. But
These people went by the book.
yeah. And here we can see a lot of synovial thickening, a lot of tendinopathy involving both the flexor and extensor tendons in this patient. And that's just chronic tenosynovitis, can be seen in rheumatoid arthritis. And then here we can see the ECU.
One problem with doing surgery on the hand in rheumatoids is that the hand looks better, but the function is not improved in most cases.
Thanks. And so here's extensive tenosynovitis involving the ECU in this patient with rheumatoid arthritis. Okay, so kind of then, so what's the upshot of all this? Well, I think, and these are slides that basically I made back in almost 15 years ago now, that effective therapy really raised the bar for diagnosis and staging of this disease, especially making the diagnosis earlier on than was made before. There are a lot of data showing that MRI accurately detects erosive phenotype in early rheumatoid arthritis. MRI is more sensitive to bone changes than X-ray techniques. Bone injury. The other thing that we found is that bone injury can progress in rheumatoid arthritis, even if they're clinically in remission and look like they're doing well clinically. Then all of a sudden they can just come down with a fracture or destruction of bones that can lead them, make them really limit their function kind of abruptly if you don't follow the bone progression rapidly and make sure that they're on effective treatment to stop the osteitis. And also papers show that tight control with newer drugs at that particular time would lead to better outcomes. One thing to remember is often the rate of progression of bony osteitis and bone destruction and erosive changes is maximum in the first 2 years of the disease, and therefore it's that early time point which is the critical time point to make the diagnosis and get them on effective treatment. And that this was a problem back around 2000 is that if we looked at the old criteria for making the diagnosis of rheumatoid arthritis from the American College of Rheumatology, basically all the criteria to make the diagnosis was based upon X-ray and other diagnostic studies, which all were based upon irreversible bone destruction, which is too late if you really want to help the patient and give them better outcomes. So then in 15 years ago, the American College of Rheumatology and the European League Against Rheumatism got together to try to come out with a new diagnostic criteria for rheumatoid arthritis, which would allow diagnosing the disease earlier on when you had reversible changes, so that you could lead to better outcomes. And in a lot of these studies back in those days, it was found that MRI and ultrasound was helpful in detecting early erosive disease. Both MRI and ultrasound can detect erosive changes well before basic X-ray can, especially MR, because we can pick up the osteitis stage. And some studies actually show that if you looked at anti-CCP blood studies and MRI, osteitis MRI, that the positive predictive value for developing erosive changes was close to 100%. So there's a big push at this particular time to try to come up with a earlier way to diagnose these patients. This is all basically things saying the same thing. Let me just go on. Oops, where's the... Sorry about that. So the bottom line is, and I think we already had the rheumatoid section, we talked about that, the ACR and European League Against Rheumatism came up with a new way to diagnose rheumatoid arthritis. And in some of those studies, it was recommended by some of the people involved in developing that criteria to use MR or ultrasound to pick up early erosive changes so that the diagnosis could be made earlier on. And I believe we went through those criteria in the previous lecture. Okay. Let me just go on here. So now let's go on and talk a little bit about psoriatic arthritis. So psoriatic arthritis, usually most of these patients will develop the skin manifestations first, and arthralgia and joint symptoms later, but not always. Sometimes the joint symptoms can come first. And these patients with psoriatic arthritis tend to have synovitis, osteitis, tenosynovitis, and periarticular inflammation within the soft tissues. And if they have any of these changes on MR, it markedly increases their risk for having psoriatic arthritis. Still a number of rheumatologists, if they suspect psoriatic arthritis, they will get an MR scan to be able to look for those soft tissue changes. Now, in psoriatic arthritis, the location differs a little bit from rheumatoid disease. Rheumatoid is in the hand, typically starts in the metacarpophalangeal joints, whereas psoriatic arthritis generally starts in the proximal and distal phalangeal joints. Degenerative disease of osteoarthritis typically starts in the DIPs, where psoriatic arthritis can affect both. You can have psoriatic arthritis and rheumatoid arthritis in the same patient, and that's seen. But typically, psoriatic arthritis will preferentially involve not just the peripheral joints, but also the tendons and the tendon sheaths. And one unusual thing with psoriatic arthritis, it will often include one digit and can leave the other digits relatively uninvolved. So in this particular case, we can see a lot of edema within the soft tissues of the second digit, whereas the other digits do not have that edema. When you have this is called dactylitis, It's very characteristic of psoriatic arthritis, and often is called a sausage digit. You always have to worry about infection in those situations, but generally infection and psoriatic arthritis will present different clinically so that you can differentiate that. In this particular case, we can see a lot of erosive changes within the bones. And here we can see a lot of peripheral disease. So this is a patient, if they don't have signs of systemic inflammatory disease, this could just be a typical osteoarthritis or degenerative disease. But in this particular patient, this patient had psoriatic arthritis. Having DIP disease as the predominant finding is very uncommon in rheumatoid arthritis. There's more type of peripheral erosive changes and soft tissue changes, as well as bony osteitis that we can see in this other patient with psoriatic arthritis. Again, very much distal disease in this patient who had a lot of inflammatory changes and typical sparing of the metacarpal phalangeal joints, also a patient with psoriatic arthritis. But you can get wrist involvement with psoriatic arthritis. Here we can see multiple erosions throughout the bones and osteitis, extensive synovial thickening. If I just saw this, I would say it's most likely going to be rheumatoid arthritis. And this is kind of a patient who could have both. Here we can see a lot of instability of the wrist from chronic inflammatory changes. And this patient had psoriatic arthritis. Poorly treated for a long period of time. And you can also get deformities if this is left untreated. Again, the metacarpal phalangeal joints look pretty good, and all the disease is distal. And here we're seeing that subluxation, which we see typically in the metacarpal phalangeal joints and rheumatoid disease. You can see it in the interphalangeal joints with psoriatic arthritis. So psoriatic arthritis tends to involve the interphalangeal joints, whereas rheumatoid disease involves the carpal bones and the metacarpal phalangeal joints. Okay, I don't know who's next. Elior, why don't you take this on swollen middle finger with skin lesions?
Right, so we see circumferential swelling about that long finger, and the DIP joint looks like there's maybe some bone erosions, bone edema.
Yeah, right.
Concern for psoriatic arthritis and dactylitis.
Right. And here on the axial images, you can see kind of normal thickness of the soft tissues on the other digits, and we can see a marked swelling of the soft tissues on the third digit, typical of a sausage digit, and so psoriatic arthritis. Here we can see a marked thickening of the surrounding soft tissues and dactylitis. Good. Tayson.
All right. 76-year-old female, long history, elbow pain, and dorsal wrist soft tissue mass.
So here's an
I'm
X-ray.
seeing a little erosion at that ulna right there, and some soft tissue calcification.
Yeah, here we can see, yeah, some soft tissue calcification there. Here's an MR scan at the wrist where they have the wrist mass.
Okay, so it looks like the third and fourth extensor compartments have a lot of synovial thickening and maybe some intrasubstance tearing of one of those extensors.
Okay. And then here we can see on the coronal plane all the synovial thickening and the abnormal signal intensity within the tendons. And this is the CREST syndrome. Calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. So the combination of seeing inflammatory change of the tendons and the calcinosis within the soft tissues. And then you look for these other things. The combination is kind of the CREST syndrome. And this is thought to be a form of scleroderma, an inflammatory disease. Okay. Elior.
All right, we see deformity of that second digit, destruction of that DIP joint, second and third. Yeah. Of course, worried about inflammatory arthropathy like psoriatic arthritis. Yeah, present on both sides. It looks like, yeah, fusion of those PIP joints on the left.
Yeah, this was a patient who had dermatomyositis.
Okay.
Yeah, so there are a number of inflammatory diseases which can affect the skin and the soft tissues in the joints, and dermatomyositis is one of them. Scleroderma, dermatomyositis, psoriatic arthritis. Okay. Let's see, why don't we stop here and we'll pick up at this point and probably finish the inflammatory section. Then on Thursday, John won't be with us. And then
hopefully I'll join you on Monday or Tuesday.
Okay, excellent. All right. Okay, so I'll
Stay out of trouble, everybody.
okay, John.
See you
Good
later.
luck on your surgery, and we will look forward to seeing you next week.
I'm also looking forward to it. Take care.
Yeah. Bye.